Hello and welcome everyone to today's webinar on promotive digital health and well-being in the context of COVID-19 pandemic. I'm Dr. Rajni Wadhwa, Director of Program Implementation at Plan India. This webinar is organized by Plan India in partnership with Empower School of Health. Plan India has taken an active and enabling role in expanding the knowledge and good practices on key issues related to gender and development and designed a series of webinars to this effect. This one is first in the series. The COVID-19 pandemic has been a wake-up call that has brought to the forefront the need for constantly innovating and highlighted the means and merits of digital solutions, be it for e-consultations, streamlining referrals and linkages, management of logistics, or availability of data which enable to reach the last mile. Empower School of Health joins in with the same vision and has tried frontier technologies, especially for capacity building and strengthening supply chains. Some housekeeping announcements. This webinar is being streamed live on YouTube and recorded to be shared on other social media sites like Facebook, Twitter, and will also be available on Plan India website. We will ensure that the entire series of webinars are available in public domain for those interested. We would love to hear from you. So if you have any questions, comments, or suggestions, please put it in the comment box below. My colleagues will be periodically peeking into this comment box and collating all the questions. And we will take it up at the end of all the presentations during the Q&A segment. If we miss on any questions, we'll email and answer your questions. So please share your details like your name, place, email ID, organization, etc., which will allow us to get back to you with responses and more updates. Let me now introduce you to Justice Madan Lokur and invite him for the opening remarks. Justice Lokur is a former judge of the Supreme Court of India and has experience of more than 4 decades in civil, criminal, constitutional, revenue, and administrative laws. He's had a distinguished career and has served the nation as Additional Solicitor General of India, Additional and then the Permanent Judge for Delhi High Court, Acting Chief Justice for Delhi High Court, Chief Justice for Guwahati High Court and Andhra Pradesh High Court. He's been judge in charge for the E Committee, and I underscored the E here, of the Supreme Court of India for computerization of all the courts in the country. He was also the one-man committee appointed to suggest improvements in the working of homes and organizations for Juvenile Justice Rules and Juvenile Justice Act. He continues to have an interest in child rights, legal aid, judicial reforms, and judicial education. He's a member of Plan India's governing board. I invite Justice Lokur for the opening remarks. Sir.
Yeah, thank you, Rajni, and good morning and good evening to all the participants, depending on which part of the world you are in at the moment. Well, one of the questions that is asked is, why are we having this webinar? I think all of you are aware that under the Sustainable Development Goals, one of the goals, that is SDG 3, the overall goal is to ensure healthy lives and to promote well-being. Now, what does this actually mean? It encompasses, as far as I understand it, and it's mentioned also in the SDG, capacity building, early warning, risk reduction, and management of health risks. Now, from the pandemic that we've had the last year, and it's continuing, unfortunately, in some other parts of the world as well, we have learned a lot of lessons, and we are continuing to learn several lessons. For example, one of the lessons that we have learned in India, and I think in most parts of the world, is that primary health care is extremely important. We must have a strong, robust system of primary healthcare that can take care of day-to-day issues. We've also learned that prevention is definitely better than cure, as they say. And as far as the COVID is concerned, something like wearing a mask or social distancing, that's preventive. So that is important. If you look at it from a different perspective, vaccinations for children, nutrition for young girls and for pregnant women, these are important preventive measures that are required. Then you have issues of what to do when a person is sick. Is there a doctor available? Is there a hospital available close by? What about hospital beds? Many countries are facing this problem of a shortage of beds because of the pandemic. So, are you going to go running around the city to find out where a hospital bed is available? Ambulances? So, there are a lot of issues in this. And the third aspect is what to do after recovery. Now, traditionally, it has been that, if you're unwell, you recover from a sickness, you recover from a surgery and get back to normal life. But there have been instances where, and several of them, where even after a person recovers from the COVID-19 virus, that person has some sort of problems, could be a backache, could be a headache, could be difficulty in sleeping and so on. So really post recuperation is also very, very important as a part of health management. So the idea of Plan India is to have an outreach on many of these issues. This is not going to be a one-off webinar. Plan India is planning to have quarterly webinars on issues of national importance, on issues of global importance, on issues pertaining to policy and nation building, rights, and so on. So really, this is the first one of its kind. And we are hoping that at the end of the program, we should be in a position to come out with a document, publish a document which will contain a set of recommendations um, for the government and for civil society actors to act in emergencies, to act in situations like the one that we are facing at the present moment. So really the objective of this webinar is to empower everybody to understand and manage healthcare. By empowering everybody, I mean all the participants here, all the frontline workers, generally anybody who is watching this program and who can share their experiences, not only for the benefit of the audience here, but for others as well. Another objective is to disseminate knowledge about digital technology. Now, this is very, very important because we've had lockdowns in several places, including a very strict lockdown in India. So, in a situation like this, how do you, in fact, get medical advice? This is where digital technology is going to be very, very important for us in the future, and we have to be ready for it so that on a computer or a mobile phone or through some digital mechanism, we're able to contact doctors, get advice, instead of having to travel to a hospital or travel to a dispensary, spend time in travel, spend time in waiting, for the doctor to be available and so on. So this is also one of the objectives, that is to share digital technology, the ideas that are going around in different parts of the world. And we have a very distinguished panel which is going to tell you about some of the initiatives that have been taken in different parts of the world. And a sort of a cross-learning and sharing of these global initiatives. It's not only completely medical, but there are also other disciplines that would be involved. And how do we all work together so that we are in a position to take full advantage of digital technology, look into issues of digital health, where something like a digital card or a health card is available so that a doctor can, through accessing that digital card or the health card, is in a position to find out the medical history of the patient, to treat, if necessary, health emergencies, and generally to provide access to health, which I believe is a human right. So really, it's a very wide-ranging sort of a webinar where we're going to look at several issues with the assistance and guidance of very distinguished panelists. And we hope that through this, Plan India is able to succeed in its outreach and come out, like I said, with a set of recommendations which will benefit the government and which will benefit civil society. So thank you very much, and welcome to this webinar. And I'm sure it's going to be a great learning experience for all of us. Thank you.
Thank you, Justice Lokur. We will definitely be coming up with all the documents as part of our advocacy kits, and we'll be sharing this with the larger audiences. May I now invite and introduce you to Mr. JVR Prasad Rao. He's the moderator for today's session, and many of you must be knowing him already. Mr. JVR Prasad Rao joined the Plan India board in 2015. He was a special envoy of UN Secretary General for Asia Pacific until July 17, and currently the special advisor for UNAIDS. He retired as a Secretary of Health and Family Welfare from Government of India. He currently leads and is a part of the committee that is as the Commissioner of Global Commission on HIV and the Law. Over to you, Mr. Rao, for further deliberations of the webinar.
Thank you very much, Dr. Wadhwa, for the introduction, and welcome to all the participants, the panelists. We look forward to a very exciting session today. This is the first of the webinar series, as Justice Lokur has mentioned. Before introducing the participants, I'll just like to add a couple of things to what Justice Lokur has said, that in the area of digital health, as he has rightly said, a lot has been done in clinical care, in reaching digital technology to hospitals and health care institutions. And India was a leader for quite some time in what we call medical tourism, basically using digital technology quite a bit in some of those clinical settings. But the area of preventive and promotional health is something which is a new tool altogether. One of the key pillars of digital health is use of tools and information to aware and empower people, to better understand and manage their health. And in that, preventive and promotional health comes very strongly. I think it is a very important part. And I think the COVID pandemic has really pushed that agenda into the forefront, because this is where, apart from clinical care, a lot is being done how to prevent the epidemic, how to trace the epidemic, those who have already got the infections, etc., how to see that we contain it. So all these are new things, and I think it is an exciting possibility to expand the scope of digital health to cover new areas of prevention and health promotion in India. So that's another issue which we would like to bring out very strongly in this webinar. And then our panelists also have done a lot of work in that area. So we thought they are the ones who will be able to reflect more on that. I don't want to take more of your time on that. But without much ado, let me first introduce the panelists to you. Our first panelist is Professor Paul Lalwani. Professor Lalwani is the founder and director of Empower School of Health, and he has launched the Center for Digital Learning and Global Health and the Center of Leadership Development in Geneva. He has worked closely with the Ministers of Health, heads of state and secretaries of health in a number of countries to guide public health challenges and strategies. He was also the former head of the Global Fund's Division of Procurement and Supply Chain, and has advised WHO, World Bank, UNICEF, and a number of other organizations. Professor Lalwani, welcome to this. And our second panelist is Professor Patty Koskova. I hope I spelled your name right. Uh, Professor Kotskova is the professor of digital health and the director of University College of London, IRDR Center for Digital Health in Emergencies. She is a world leader researcher in the novel interdisciplinary domain of digital public health. Professor Koskova's research was applauded through a number of prestigious awards, including Innovator of the Year 2019, Winner Computing Women in IT Excellence Award 2019, Team Leader of the Year 2018, Finalist Computing Women in IT Excellence Award 2018. A number of such awards he has got. So welcome to the panel, Professor Kotskova. The third panelist we have is Mr. Love Agarwal, who is the Joint Secretary in the Ministry of Health and Family Welfare. Mr. Agarwal is an alumnus of the IIT Delhi, Indian Institute of Technology, Delhi, and he joined the Indian Administrative Service in 1996. He has proved to be a seasoned administrator and a technocrat who has served the country in a number of positions in the domain of housing, education, climate change, and disaster management, to name a few. Currently, he serves as the Joint Secretary in the Ministry and plays a very key role in India's response towards COVID-19 pandemic. He is instrumental in rolling out the telemedicine program during COVID-19 pandemic. So he will be able to speak on behalf of the government. So we have three distinguished panelists here, and each one of them will get about 10 minutes time to make their presentation. And I was told they all have PowerPoint presentations, which is really good. And after the presentation, we have a Q&A session. So those of you who are watching the webinar may post your questions on the YouTube, then they will be passed on to me, and I will throw the questions to the panelists, which are appropriate actually for each of the panelists. That's how we organize the webinar. So our first panelist, Professor Lalwani, over to you to make your presentation.
Thank you very much, Dr. Rao, for the kind introduction. Justice Lokur, it's a pleasure. Thank you very much, and an honor as well. Plan team and participants, I look forward to this. May I request someone to share my slides, somebody from the plan side. And while we're doing that, I'd like to just briefly state that. So my presentation will set out the stage for what is digital learning, how it is structured, what are some of the examples of what is being done here in India, and how we can ensure and help scaling of these solutions across India as well. Can someone tell me if you're sharing, or would you like me to share the presentation myself?
I think if you have the presentation, Professor Lalwani, you can share it, because that saves us time.
Yes. Let me do that.
And as you do that, I can also just add to what you have already said about your presentation, and how the digital technology could help in capacity building, especially in equipping the skill sets of frontline health workers in the context of COVID-19 pandemic and beyond. I think that is something which you may like to highlight, and also the role of digital health in the present times, how it impacted the COVID world, basically.
Indeed. I will definitely do that. Let me do a full screen share. You can see my screen, okay.
Yes.
Let me, of course, I have the rainbow wheel, so just give me a second. So yes, indeed, we are emphasizing how do we get, because we cannot possibly roll out any of these technologies and solutions to the last mile unless we build the capacity of the community health workers and the community themselves as well. So sorry for the delay, it's still spinning. Here we go. This is a full screen share.
Yep.
Can you see the
Yeah.
screen okay?
Yeah, fine.
Yeah, okay.
Perfect.
Let me do this now. So the role of digital health and India. So our mission, our organization's mission is to transform the way people learn, work, and save lives through digital learning. So we really rely on digital technologies in this particular space. Why did it do that? Sorry. There we go.
Yeah.
All right, very briefly about Empower School of Health. We are working across more than 100 countries, working with ministries of health, UN agencies, WHO especially, and various donor agencies to build capacity. And we do this with partnerships. And of course, India is one of our main area of focus. Sorry, not sure why. Sorry, I don't know where that music is coming from. Is there music in your background?
We are not getting any music. You can go ahead, no problem.
Okay. All right. So clients, funders, and partners, we are working with all these different organizations, domain areas, global health leadership, global health supply chain, including COVID and other areas, new product introduction, which is really important, especially when we talk about COVID, medical lab diagnostics training, especially as we move these to the last mile, and health workforce strengthening across, especially ASHA, Anganwadi workers, multi-purpose health workers, etc. So let's first try to understand digital health technologies. And I'll start with it first at the person-centric level, and even the digital health mission, National Digital Health Mission, it's all about person-centric. And we keep hearing about different elements of what is digital health. So first, let me speak of it from an individual point of view, how you as a person would interface with it. And then I will speak later about from an organizational and architecture point of view, how it is structured to be able to deliver. So you keep hearing about, smart watches or trackers or your mobile phones being used. But beyond that, and very interestingly, there are now smart shoes, smart socks, smart shirts, smart rings, smart glasses, everything trying to be more intelligent than we are in order to make sure that your health statistics are available on a continuous basis, which becomes fundamental as we talk about preventive and promotive health. So take a look at this example where on an ongoing basis, this data is captured and it creates a profile. It could be anything from your weight, your exercise routine, your sleep, your state of happiness or anxiety, your cholesterol levels, your blood pressure levels, what medications you're taking, what vaccines you've taken or not taken. And all of this leads to a profile, which then can tell you if you are prone to any particular disease or if you're healthy or what you should be ready for in the coming, or alter your behavioral habits in terms of sleep and exercise and food so you don't get sick. So it's both preventive, promotive, and all relying on different kinds of tech. So now if we look at it from a technology, that was person-centric. If we look at this from a technology point of view, you will hear these kinds of different categories. Remote sensing and wearables, telemedicine, and health information, health wellness behavior, bioinformatics, wireless communication, electronic medical records, and many more. So this is now referring to the architecture more from a technology point of view. When you look at the ecosystem of digital health, who are all the stakeholders who are going to be involved? And I borrowed this chart from the National Digital Health Mission, which positions this very well. And if you look right at the center, it's about citizens and patients. And citizens, because we're not patients yet, many of us, but we need to be, the target group is for preventive and promotive healthcare. And all around are the different stakeholders, the providers, which are the hospitals, clinics, labs, pharmacies, the allied private entities, those providing technology solutions, medicines, insurance, etc. The healthcare professionals with whom we must engage so that they can actually deliver, the frontline workers, NGOs, administrators, policymakers, of course, governments, etc. But in the center, if you'll notice, it's citizens and patients. But none of this would be useful unless we look at these key areas of how do we make sure that the digital health elements we are talking about are efficient, accessible, affordable, timely, inclusive, and safe. And we'll talk a bit more about this as well. Inclusive, you can understand the importance, because later on we talk about the digital determinants of this particular sector, not the social determinants, but the digital determinants. Do the individuals at the last mile have access to digital technologies? Do they have electricity? Do they have digital literacy, etc.? Right? So those components on the right-hand side are just as important as the elements of the different stakeholders. So after having jumped in, so what is digital health? So digital health is the use of information and communication technologies to prevent diseases, treat patients, conduct research, educate healthcare professionals, track diseases, and monitor public health. It's a combination of all that. And there are various examples. I won't go into detail, but just simply list at the highest level some of the examples of different areas that are currently being implemented across India. So one is the Integrated Health Information Platform, covering 33 epidemic-prone diseases. 30% of the population is covered, and the data entry is envisaged from 200,000 health facilities. Then you have the Comprehensive Primary Healthcare Program, operational in 20 states with 80 million enrollments and 13 million people screened for hypertension, diabetes, 3 common types of cancer. Another couple of examples, and this one is on focused on pregnancy, childbirth, and childcare, currently covering 19 million mothers and would-be mothers. Another one is a mobile academy, working closely with maternal and child health and aimed at knowledge and communication skills of ASHA workers. Then when we talk about digital health initiatives, there's another one for TB patient monitoring system of NICSHARE, run by the government of India. It's a web-based application for monitoring TB patients. It's received global awards, and it's one of the best. Another one, the National Health Mission is managing as a blood banking management system where the donors and the recipients can coordinate and organize everything on a web-based tool. Another one for digital supply chains, for vaccines, for ministries of health. Another one for telemedicine. So this gives you a sense. This is not new. This has been going on for almost 20 years. India is one of the leaders in this space. But the 6 elements that I mentioned earlier, is it equitable? Is it affordable? Is it accessible? Those elements still need to be scaled. And the National Digital Health Mission, from whom you'll hear Mr. Love Agarwal, will give us much more information on how they plan to scale these initiatives. So I provide a quote from the WHO. This is their current digital health strategy for 2020 to 2025. And what they have jointly developed with member states. What they say is the strategy recognizes that digital health can radically change health outcomes if it is supported by sufficient investment in governance, institutional and workforce capacity building. And the second part, which I'll mention and then connect the dots, the digital determinants of health must be ensured, which include literacy in information and communication technologies and access to equipment, broadband, and internet. So we definitely do not want a situation where we have fantastic tools and solutions, but they're not made available to everyone. So make sure there's no digital divide, or limit the digital divide, or overcome the digital divide. And at the same time, ensure that our workforce, which number in more than several million, 2 to 3 million, our health workforce, have the capability and the capacity to deliver these solutions at the right level and scale. A similar quote from the National Digital Health Mission, where they clearly identify and highlight that the National Digital Health Mission will educate and empower individuals to avail a wide range of health and wellness services. And mass awareness and education will be promoted through the use of appropriate platforms and a portfolio of health apps. And I really like the phrase that NDHM is building its principle of scale on, is think big, start small, scale fast. And it is, for a country like India with 1.3 billion people, given the crises we are currently facing and will continue to face in other forms, this is exactly what is needed. And it's something that the government of India can do very well. So building on the point that Dr. Prasada Rao mentioned, capacity building of community and community health workers. So what are some of our experiences? And as I mentioned, we are doing this across more than 40 to 50 countries in more than 20 languages. But here I just give 3 or 4 examples of what we're doing in India. One of them, working with the Ministry of Health and the TB department, the National TB Elimination Program. We've digitized and designed and developed their entire e-learning program, along with partners such as the Union, WHO. This was funded by USAID, and this program will go on for another 4 years, where we continue to support them. And there are several other partners as well, with, of course, National TB Elimination Program being the lead one. Another program that we have recently started, and this is the target group here, is the frontline health workers, including ASHA, Anganwadi workers, ANMs, and school teachers. And the focus is on the implementation of rapid and emergency training solutions to respond to the COVID crisis. How can we quickly do that? How do we measure the impact? And this one is along with Save the Children. But in many cases, and going back to the issue of equity and access to the last mile, what if there is there's limited electricity? What if they don't have smart devices? What if they don't have Wi-Fi and broadband? So Empower has, in partnership with other organizations and getting research and feedback from others and picking up on global experience, designed a digital classroom for the last mile, where we don't need electricity, we don't need Wi-Fi, we don't need any bandwidth. All the information is preloaded and shared in tablet PCs and can be easily updated and adapted on an ongoing basis. So the facilitators can literally take this to the last mile to educate and train not just health workers, but also communities and families. If you're talking about reproductive health and family planning, you can do it in small groups, you can do just girls, you can do just children, or you can even do one-to-one. So this was the last slide, and really brings together the combination of possibilities of different elements of digital health, different technologies, and making sure there's equity and access as we move forward. Thank you very much.
Thank you. Thank you very much, Professor Lalwani. You have introduced the digital determinants of health. I was almost tempted to ask you whether this is going to increase the economic divide across the country, but I think you have lastly answered it by talking about digital classrooms for last mile. I think that probably is the solution, because otherwise if you have to depend upon all the time for equipment, the broadband and internet as the requirements, then probably the divide will increase actually. So I'm happy that you are thinking in terms of this, using these digital classrooms for last mile, which is an excellent example. Thank you. Anyway, we'll be having more questions on that. I would now turn to Professor Patty. A couple of issues I would like to pose, Professor Patty, for you to reflect upon while making the presentation on how health-seeking behavior gets addressed globally using digital technologies, and how is DT used for increasing awareness and uptake of health services. And it has been used much in clinical setting for care and treatment earlier. But what is your perspective in using the digital technology to strengthen public health in non-clinical settings for prevention and health promotion? Over to you.
Thank you ever so much for this lovely introduction, and it's my real pleasure to join you today, giving this very challenging and exciting webinar back in India. So it's morning in Europe at the moment, so I send my best regards to the evening part of the world, and I will give a very short presentation bringing some of the challenges and opportunities from global perspective. Let me just share my screen now. Can you all see my screen?
Yep.
Perfect.
We can make it full screen also, I think.
If it goes to the show mode, it may not be able to. You may have to share it differently.
No
I
problem.
will just,
no
I will
problem.
just go.
Please go ahead. Yes.
Yeah. So understanding global perspective on digital health. So kind of following up from the scene so well set up by Paul. I'd like to focus on three aspects on global delivery and opportunities given by digital health. One of them is looking at early warning and response, and how technology, and specifically big data, can enable us to better prepare and better respond to emergencies, epidemics, and now we're all very familiar with pandemics like COVID-19. But it doesn't start with COVID-19. The work which were provided to us and the opportunities offered by big data goes way back, as you will see from my first example. I really like in the introduction, we have looked at not just clinical settings, the opportunities of digital health, in particular using mobile technologies, go way beyond clinical and healthcare settings. It exactly goes to the public health, giving opportunities for people in their homes, in their communities, to better understand their health, make better healthcare choices, and be able to manage their health independently and, of course, much cheaply on their own, in their own home. And I give you a very exciting example for one of the research projects we've done with rural women in Nepal on this aspect. As we have discussed, training and capacity building is absolutely essential to mobilize and improve our workforce and streamline healthcare delivery in 21st century. Mobile technology and the novel approaches like serious games and persuasive games have provided numerous practical examples how technology can change the delivery of health and change behavior of clinicians at the point of care. So my third excursion will go to Africa, where I will demonstrate our award-winning project called GASDA, changing the decision of clinicians at the point of care with regards to antibiotic prescribing. And this is just an example of a very successful training projects. We are looking into scaling up across Africa and also other continents to really deliver much better capacity on the ground at very cheap and affordable level. So let me tell you for this excursion. So yes, big data for early warning, and it's very, very topical now in the COVID time, but it goes all the way back to 10, 15 years ago when big data had started to be generated through multiple IoT sensors and social media. Obviously, online searches have been really popular. Google has pioneered the Google Flu Trends initiative more than 10 years ago, although lately it was shut down because it wasn't as successful as they wished initially to be. So going back to the previous pandemics and 2009, the swine flu, my research group was one of the first to pioneer the opportunity of using social media. We used Twitter at the time. It was a very novel and geeky social media platform, unlike now when we have politicians and all the companies on Twitter on a daily basis, including a lot of trolls and subversive players spreading fake news. So this goes back to the early days of Twitter when there were no fake news. So we didn't have as much noise in the data as you would have to deal with today. But we have collected data set in 2009, which at the time looked impressive. We had over 3 million tweets discussing some aspects of influenza and the swine flu pandemics. 3 million tweets would be collected in a few minutes these days, but back 10 years ago, just to see how the decade has completely changed the way we approach data communications and how social media revolutionized the way we share and receive information. 3 million tweets, in 2009 was a massive data set. And we looked at it in terms of understanding how the discussions could actually show a signal which could perhaps give an early warning opportunity to healthcare professionals preparing to respond to swine flu. And as you can see on this slide, the data collected by Twitter, there was self-reporting tweets. We have kind of filtered from this big data set where people have been reporting their feeling they had the swine flu or someone else in their family or friends had a swine flu. This is the kind of the darker, the gray line with the peak, the spring peak, which was around May 2009, being just here. And you can see the official data, those square dark black boxes from the UK RCGP system, which is the official GP-based data collection from GP surgeries, where people presented with swine flu. You can see there was about 2 weeks time lag. And 2 weeks in pandemic is actually a long time in terms of mobilizing resources, preparing the workforce, perhaps changing the way you orient to hospitals in the anticipation of hospitalizations and severe cases. Of course, we all know now that swine flu initially was looked at like as a big pandemic, actually wasn't as severe. And the hospitalizations and death rate were not as significant as we are now witnessing with COVID-19. But still, demonstrating the opportunity of social media to early warn the authorities 2 to 3 weeks before the spike hits the system is actually a very long time to mobilize the resource and improve preparedness and, of course, a response. Well, in 2019, big data has changed, and we can now collect data from social media, from weather systems, from people personally responding and making the authorities, like in the UK or many other countries, aware about their symptoms on a daily basis. So participatory surveillance has now become one of the major components of data collection, right from the ground, crowdsourced to citizens globally. We now work with our colleagues in Northeast Brazil, where we have a spin-off a new COVID project based on our multiple years lasting activities around the Zika virus. Although Zika virus was in the news in 2014 when the epidemic hit Northeast Brazil, it's still going on, but it's no longer attracting so much media attention, of course. Keto spread and identifying hotspots to better combat Zika virus. However, working with our colleagues on the ground, we quickly spun a new activity looking at how we can bring together our modeling systems and our existing data sources in Brazil to actually predict and prevent a COVID-19. Unfortunately, Brazil is one of the countries which hasn't got a very good government response. There's a lot of confusion going on from the federal government, and the states, in particular the Northeast Brazilian state of Pernambuco, are really doing a great job on a municipality and a state level to try to communicate a clear message and using technology and AI techniques to respond. So in this picture, one of the data sources we're using, which obviously wasn't available 10 years ago for swine flu, is also using drones. So the drones are monitoring big cities and markets because many people can't afford to self-isolate in Brazil because they rely on their income to feed their families. So the whole situation, without the economic support from the government, we we can see in Europe is unfortunately really difficult. So the authorities are monitoring the spread of people in public places, markets, and in a high density dwellings, in favelas, so-called in Brazil, to better understand where the hotspots of transmissions in community could be. And they're predicting the cases to help the authorities to respond as and when the cases may rise. So moving on public health education, well, as we have discussed at the beginning from the introduction talks, it absolutely is clear that the technology now gives us an opportunity to move healthcare from the clinical setting, from hospitals to the community, and empower people on the ground to take better care of their health, be better educated and informed, and also make better health choices. And the project I would like to show you here is a project in Nepal. We've done a lot of work in public health, working with children. We work in schools to empower kids to better understand their health. We have done some work in the UK about infection control for communities and citizens. However, this project really shows the massive opportunity we have with mobile technology to really reach as far as people actually are living and give them the power and understanding to better manage their health. We worked in Nepal a couple of years ago with rural women in a district called Kavre, which is south of Kathmandu, which was one of the worst hit districts after the 2014 earthquake in Nepal. The people are living in very, very remote settings. They have to walk hours to the nearest hotspots. Their access to healthcare facilities is extremely limited because of the obviously low income setting of the country, the massive distances between the villages and the cities, and also a very challenging geographical situation. So people have to walk through valleys and mountains to get to a hospital to deliver a baby. And this project particularly looked at newborn and maternal health, which highlighted how challenging the situation was for pregnant women in Nepal in 2014 who were delivering their babies or needing a pregnancy care while the earthquake hit, or the months after the earthquake where the aid and delivery was still, in its infancy. So this project is looking at how we can use technology to give women better understanding about some of the issues they may face as during their pregnancy and maternal health and the health of their newborn babies, and how mobile technology can empower them to make the right choices, to know when the condition is critical and they should really be transferred to the hospital the fastest possible way, while often it means being carried by the hospital or by the family members to the hospital if they can no longer walk or if the delivery has started. Really critical situations. And also reassure them that, in some cases, certain conditions with their baby and with their maternal health are in fact normal, and they don't have to worry about it. They don't have to be seeking immediate health care, and they can just stay at home and look after themselves. So the women are mostly illiterate, and they just meeting in their groups like this once a month, supported by volunteers, senior women who trained by the government to deliver kind of basic healthcare education and primary care in Nepal. And they're learning about their health, about health of their babies, about farming, nutrition, and all these important aspects through discussions in these women's groups. So because a lot of them are still illiterate, unfortunately, the mobile game we have developed to improve their knowledge was entirely pictorial. There couldn't be any words, any numbers, anything, because some of them don't even know numbers. So you can see some of these pictures on those two examples where we were trying to depict certain conditions on maternal health and neonatal health. It was developed in collaboration over iterative co-creation process with those women in those villages and our collaborator in Kathmandu, a charity called HERT, to really make sure it was culturally rooted, they understood the conditions, and they were kind of getting the idea of how to play a mobile game. And the first focus group we did with these women was amazing. Some of them has never had a smartphone in their hands. Some of them only use a touch phone, and some of them don't even know how to use touch phone because they don't know the number. So they can just pick up the phone when someone rings them, right? Also, it's a very patriarchal society. So if there is a phone in the family, it's often the husband who has the phone, not the women. So they felt amazed about being given, an expensive in Western standard, in their standard, but not in Western standard mobile phone, as proper smartphone, and they were playing with the phone. Basic things like using touch phones and drag and drop features, which we adopted as the simplest navigation. It took them a few minutes to understand how to use it. And once they got it, they absolutely loved it. So in a few minutes, the women could use the phone, they could play the game, they understood the pictograms because they were culturally appropriate, and they understood they should choose between critical conditions where they need to be calling an ambulance, or as I said, in some cases, if ambulance can't get there because of the emergency or road being blocked or stones falling on the road, they have to be carried to the nearest health post. And the yellow building at the bottom is a nearest health post to one of the villages where we worked, or where they could be empowered by the game that actually some conditions, you know, like infection on their baby is not as critical. They can just wait for the local nurse to come around once a week to their village. There's nothing to worry about. So empowering them was something they felt really excited about. They felt they're gaining a better understanding. They also were loved to share the ideas. They didn't seem to play the game themselves. They always shared the screen with someone else next to them, and they were discussing it together. So it was a really interesting to see how these women actually played and how much they enjoyed it, basically. And obviously on the kind of scientific side, we demonstrated they improved their knowledge. So there was a significant knowledge gain around those three topics. And there was also a very positive feedback from the focus groups in the qualitative part of the study we have done in those villages. So now we're looking for additional funding to scale it up in Nepal and in other Asian and African countries where people live in so remote situations and would take benefit, not just around maternal and neonatal health, but also around other important primary care subjects. So that's an example, you know, how far we can go to actually improve health in a community on the ground. And this is only possible through mobile technology. Finally, moving back to clinical settings, Plant has been doing amazing work around training and capacity building. And without training and capacity building, we're never going to revolutionize healthcare. So really making sure professionals on the ground are as well trained and as well equipped to do their work is absolutely essential. The project GASDA is an initiative in Nigeria, which is looking at one of the major concerns of 21st century, that's antibiotic resistance. It is expected that antibiotic resistance can cost about millions of lives and about 50 billion in revenue by 2050 if it's not tackled. So the GASDA is looking at one of the components of the strategies globally we're putting in place to address antibiotic resistance, and that's overprescribing. So how do we limit overprescribing? In Nigeria, we work with partners in 3 teaching hospitals, in Lagos University Teaching Hospital, Lagos State Hospital, and in Niger Delta Hospital down in the Niger Delta. So we have 3 different clinical settings, 2 of them being in the capital, a better resource, and one of them being kind of a tertiary setting in the Lagos Delta. This is what they look like, just to give you an idea what settings this project was developed in. And what we have developed have, again, a very much kind of an iterative project in collaboration with the local experts, using co-creation and co-development approaches to make sure the mobile game or the mobile decision support app really met their expectations and the process they use in the clinical settings. So we did focus group, we did online surveys, we did a lot of group testing of the first prototypes of the game. And then when we have developed the final kind of pilot version, it was evaluated in those 3 hospitals over 7 months period last year. And this year we collected some of the data and published it. The decision support system quite often seems really, really difficult and boring to use. However, we have applied.
Patty, if you can take 1 more minute to close your presentation. Yep. We have some questions also. You can come back.
Yeah. So we have applied gamification features to give positive and negative feedback to users with regards to their decisions about antibiotic prescribing. And we also applied some of the gamification award features to encourage people to use the app longer, which was no problem for the 6 months of the pilot study. We got very positive feedback from the surgeons in Nigeria in all 3 hospitals. And as you can see on the last slides, we really demonstrated a behavior change, improvement in their clinical decisions about prescriptions. So lower down the prescriptions rates and the length of the prescriptions around those operations which were part of our study. So yeah, so mobile technology can take us to any part of the world and can help us to improve clinical settings, can help us to improve health in a rural settings in a whole, and also can help us using the big data in a global way to prevent pandemics. We got loads of awards and prizes. I'm not going to go down to these details. And I would like to thank you to all the team members in the Digital Public Health Center in Emergencies in the UCL for joining me for all the work over the years to deliver so many amazing results. So thank you so much for your attention.
Thank you, Patty. That's a very informative presentation. I was really charmed with your idea of drones for big gatherings. I wish we have something like that to cover our political meetings, where we could have tracked COVID-19 much more effectively. But it's a good use of technology. Maybe sometime later we can get more information on that from you. But now our third panelist, Mr. Agarwal, will join at 5 p.m. So we have some time for questions in between. I have a couple of questions already on my chat box. I will just take them out and sort of give it to the panelists. The first question is to Professor Lalwani by Akanksha Sharma. You have given an example of dots of TB tracking of the people on a daily basis. She wants to know how many portals like dots is available for various diseases.
It's an excellent question, and I really wish Dr. Love Agarwal was here to answer that. We've been working in TB, so we have a good sense of that. But Mr. Agarwal would definitely be able to respond to that question. If I could defer to him, that would be appreciated.
Yeah, right. So maybe we'll, when he comes, we can ask him that question. There is a question to Patty. It says health-seeking behavior is critical for girls and women. In case where there is a huge digital divide, how do we make sure that the digital health technology reaches to users who are in most need?
Thank you so much. This is a very good question. I think the digital divide issue has been one of the most important issues we've been facing in the last 20 years globally, because the technology enables people, just like, you know, I showed the women in Nepal, but also it does not enable people and creates a massive gap for those who cannot access the technology. I think in the good sense, mobile technology has become really affordable. So even in Nepal, one of the poorest countries in the world, there's 1.6 mobile phones per person, per citizen in Nepal. Obviously, it doesn't mean everyone has a phone. Some have more than one phone and company phones, but it is quite reassuring that even in Nepal, the technology is reaching the community. Obviously, it is becoming cheaper to manufacture and cheaper to afford mobile plans. So in the next 5 to 10 years, it will be affordable and reachable to all ends of the world.
Thank you. Welcome to you, Love Agarwal. I'm happy that you could join, and then we have already introduced you to the panelists and the audience. I would now give the floor to you, and we have a couple of key questions which we would like to pose to you for answering. First of all, you are looking after the National Digital Health Mission. So if you can tell us about the objectives of this mission, which was launched by the Honorable Prime Minister in August, and then how does it enable, strengthen the promotive health in India, preventive and promotive health, and also you're going to unleash a huge vaccination plan for COVID-19. How are you leveraging DT, digital technology, to boost the uptake of COVID-19 vaccination in India with a focus on reaching the last mile? So over to you, Mr. Lava Agarwal.
Yeah, thank you, sir. I think first at the outset, let me express my sorry for being late for this discussion, because I was supposed to attend another emergency task which was given at the last moment. So as to cover the issues which are being discussed right now, what I would just like to highlight, I would just like to take everyone through a small snapshot of the bigger picture, wherein I think the point which you have highlighted will also get covered. So, you know, the overall journey. So if I were to say, sir, what we have kept for ourselves from Government of India perspective is that how digital health should actually support Government of India in the overall framework. And we have sort of identified that digital health is one of the lowest hanging fruit in terms of actually making the overall health system more efficient. And as part of leveraging digital health to support universal health coverage, we propose that our whole framework should be creating electronic health record for 1.3 billion people, which is interoperable in a very secured manner. And further, in terms of services, we think that there should be a pan-India telemedicine network. There should be pan-India surveillance and monitoring of all the health ongoing programs. Surveillance, I need not highlight primarily because of the fact that we're all aware that last 1 year particularly has highlighted the need for ensuring timely surveillance, timely data so as to take meaningful intervention at the field level. It is also equally important that we focus on utilizing technology as a tool for capacity building and training of multitudes of health workers spread across such a huge country. And parallelly, it is equally important that digital tools are put to use in terms of creating overall communication with the community, communication with the patient, so that the health seeking behavior overall can increase in the country. And it is with these as objective, we have already taken few of the steps. And if I were to identify those steps, they fall in different buckets. So one is planning and monitoring, focusing separately also on the health information system, creation of public health solutions, ensuring required supply chain management, how do we manage emergency response, and how do we prepare an interface for citizen. Just to give a snapshot of multitude of activities on the digital health arena, which Government of India has been working on. So in planning and monitoring, we have come up with a overall architecture approach in terms of digital health mission. I would be talking about it later. We've also come up with creation of required health standards, health data standards, standards related to privacy and security. We have been talking about creating application where the data gets collected at source. From a digital health perspective, the most critical element is that if we are able to collect the data at source, then the collation of data becomes easy. So that is where applications like e-hospital or e-shushru have much to add. Similarly, from a public health solution point of view, we are all aware that our immediate focus has primarily been on in terms of maternal child health. So we have such applications which are widespread used across the country. To give an example, 120 million children and 140 million women are being monitored historically through this maternal child health application. Then similarly from supply chain, we have drug and vaccine distribution system, blood bank management system. And in terms of emergency response, I can just submit that the most important component of our response in the field level has been the digital health intervention, which made government aware of what to be done when in a very, very preemptive manner. And then from a citizen interface point of view, I would specifically like to highlight online registration system, wherein across the country in major hospitals, in government hospital, you can actually take online appointment. And parallelly, you can also give feedback through Mera Aspatal application with respect to the services provided by the government setup. In terms of what we are talking about COVID-19 management, I would just like to highlight here very specifically, what are the core capacities, what are the core interventions which are required to be taken when it comes to managing a pandemic. So if you were to see, they are primarily surveillance and contact tracing, focusing also on the required logistics, ensuring that laboratory testing infrastructure is in place. We also need to see that we prepare hospitals to manage such an infectious disease. And also we have sufficient capacity in the system in terms of that every nook and corner people know from health professional perspective what to do. And how we engage community in terms of making those meaningful intervention, take their support. And probably the last leg of this is the vaccine distribution. I think whole spectrum of the COVID-19 management has actually been supported by these interventions. To highlight, Arogya Setu is one of the most downloadable applications in the world. CoWIN, I would like to talk about it later, is again going to help us in terms of managing approximately 1.3 billion people vaccine distribution for COVID-19. Logistics were managed through different COVID-19 portal. Laboratory testing was managed through RT-PCR app for registration as well as CV analytics portal for overall analytics in terms of understanding what is the testing trajectory of the country. We had multitude of apps to support, be it the facility app for clinical management, e-Sanjeevani app for managing telemedicine, and similarly we had training resources made available through iGot platform, which is the integrated government online training platform through which 16 million COVID warriors were trained. So the point I'm just trying to submit is that the whole spectrum of activity wherein government need to actually take an intervention, make an intervention, was supported through digital health as a tool. And I would also like to specifically highlight that country with such wide variety of geography and with so many rural and remote areas, telemedicine we have identified as one of the major application. And we had actually created a e-Sanjeevani telemedicine app, which is primarily generic drugs based e-prescription wherein they are enabled. It is also based on the EHR guidelines of the Union Health Ministry. It has also facility to import wirelessly the point of care diagnostic devices data so as to ensure that there are no data errors, inbuilt video conferencing, and various dashboards. So this is the application which became one of our starting point in terms of Ayushman Bharat Health and Wellness Centers. We also realized that when COVID was much more in virulence in the sense that larger number of cases were reported and country was trying to grapple and understand what COVID-19 is. It is at that time we came up through Board of Governors telemedicine practice guidelines, which allowed registered medical practitioners to start using telemedicine. And we modified our e-Sanjeevani application to provide a common person interface. So it was like regular OPD consultation. And I would just like to highlight, right now it is operational in 28 states. More than 7,700 practitioners have been trained and 14 lakh plus consultations have been rendered, making it the biggest telemedicine platform in the world by a margin. And it is this same application which Government of India is now providing for Pan-African Telemedicine Initiative through Ministry of External Affairs. I would also like to submit here for everyone to highlight that it was a COVID India portal wherein we actually got so much of data from state and districts. We were doing case monitoring and patient matrix analysis. We were doing analysis of how the testing is happening, which districts are doing less testing, where the testing positivity rates are high. We are also identifying fatality rate monitoring through the treatment analysis protocol. We are also seeing whether sufficient number of facilities are there in every district based on the caseload through the facility dashboard. And similarly, whether ambulance, is there any delay in terms of getting ambulance, etc. How the quarantine is being monitored, particularly in every district of the country, and wherein how many oxygen beds are available, how many oxygen cylinders are available. This is all monitored in last 1 year. And I think that is where I would like to submit that it was the digital tools which provided us a lot of understanding in terms of what we have to do at the field level. Similarly, we had this facility app wherein also the inventory management and patient case record can be built in. So if a patient has been normal now, but suddenly there is a cytokine storm, and if his treatment has changed from there, if he has gone from say oxygen bed to ICU bed, the whole trajectory of the patient could be monitored through this particular application. Arogya Setu, I need not highlight, the biggest, most downloaded application in the world, 190 million downloads across the country, wherein we were able to support the overall contact tracing, syndrome mapping, and self-assessment so as to create a digital coverage around a person in terms of making him understand that this is the distance he has to maintain and promote social distancing as one of the non-pharmaceutical intervention for management of COVID. We had RT-PCR app, which was used by 40,000 collection points across the country, wherein any sample collected was monitored so that we are able to identify early if a person has become positive and do the required contact tracing. I would also like to highlight the points you mentioned is about COVID digital platform for COVID-19 vaccine delivery. What are our challenges? Our challenges are there will be multitudes of vaccines which may be available. 2 of the vaccines have already been approved. Each vaccine will be given in multiple doses, say 2 doses oblique 3 doses. And similarly, the vaccines are non-interchangeable. Then third parallel challenge is that these vaccines have to be given across the country. The whole logistics needs to be managed. While we had universal immunization program where we are catering to around 3 crore vaccinations per year, therein we are talking about, if not 1.3 billion, at least in the phase 1 and phase 2, approximately 30 crore people to be vaccinated. So while we had the best immunization program in terms of numbers in the world, even the magnitude of that program has become now 10 times. And that is where technology is going to play a major role. wherein we'll have mobile app for recording the vaccine data. We will be monitoring 29,000 cold chain points through temperature logger remotely, and each and every beneficiary, we will be tracking him for what vaccine has been given to him, which dose is being given to him, did he miss his second dose, what are the corrective actions to be done so as to ensure that the second dose is given right time. So this whole process has actually been initiated. I am very happy to highlight that on 16th of January, Honorable Prime Minister will be launching the vaccination drive. As on yesterday, 1 crore people plus healthcare worker and frontline data is already available in our application, which is being monitored. This particular application has module for self-registration. We haven't launched it though. We will wait for it to be launched at the right moment. And similarly, there is facility to bulk upload the data and the registration by surveyor. And then there is a vaccinator module where each and every vaccinator can actually enter his details, map, and session allocation can be done, based on which beneficiaries will get SMS in 12 Indian different languages. 6 SMS goes to each and every beneficiary in terms of telling him where his session has been allocated, what date, who is going to the vaccinator. There is also a proper protocol-based adverse event following immunization monitoring. This will be one of the biggest platforms in the world in terms of managing the overall processes. Now, while we are working on multitude of these applications, I would also like to highlight the challenges. Now, these challenges are not new to India. These are probably the challenges which whole world is facing when it comes to digital health. I always very in a lighter vein say that whatever gap in terms of communication or delays in communication has happened in physical world has also translated in the cyber world. That's why you have silos of information existing in different applications. There's duplicacy in data collection by multitude of applications. Interoperability becomes a major challenge. So since there is no interoperability, you cannot actually create a longitudinal health record across the system. And to that extent, the best advantage of digital health cannot be obtained. So there is a need for a national level information exchange. There is also need for common data analytics platform. With this in mind, Honorable Prime Minister, post creation of a national digital health blueprint on 15th of August last year, announced the launch of National Digital Health Mission. This talks about creating an accessible, affordable framework wherein we are able to leverage open, interoperable, standard-based digital records and ensure that this electronic health record in turn can support precision medication. How this ecosystem will help us is that it is going to integrate every health-related transaction primarily through various registries, in terms of registry for patient who is uniquely defined, registry for health facility which is again uniquely defined, and registry of provider which is again uniquely defined. Once we are able to create these registries and then populate it across the health data which is now presently existing silos, we will be talking about a mechanism where the different applications be and the different users, be it central government, state government, hospitals and clinic, labs, even insurance and health tech companies can all come together into a framework and support the overall creation of electronic health record as well as the precision medication for the people. I would also like to highlight that it is not what we are trying to do in India, which is important for us. Actually, India is driving the agenda of digital health across the world. It was on the 71st World Health Assembly in 2018. India moved the resolution on digital health, which was unanimously agreed by all the countries. So we were able to push even every other country to start prioritizing this agenda. Then the Global Digital Health Partnership, which is the biggest intergovernmental partnership on the digital health agenda in the world, with 30 countries and World Health Organization and 3 observers, which is what has been done today because 2 countries and OECD applied for its membership, and our process is that we take them as an observer for 6 months and then we give them full entry. So around 30 countries plus WHO and 3 observers now are there, wherein we are focusing on agenda of government as a whole approach towards creating a digital health ecosystem. India is currently the chair of that Global Digital Health Partnership. We recently conducted 7 summit. We had participation from 19 countries, academia, industry, and startup in that Global Digital Health Partnership Summit. We also had a Delhi Declaration of Digital Health in one of the summit when we hosted that in India last year. And focus here is that how do we sort of leverage what is happening in India, how do we sort of leverage what is happening across the world and bring them together so that we can create digital health as a global good for everyone to utilize. What is our way forward? I would just like to highlight that India has a strength on digital health agenda. India has a strength on e-health as well as also digitalization per se. So we want to position India in terms of continuing taking that leadership, help create within the country national digital health ecosystem, an overall digital health framework where all stakeholders can get involved, ensure that we have a telemedicine system which supports availability of specialist care even in the remotest part of the country. We also need to focus on, while we create this framework, how do we leverage artificial intelligence, Bluetooth enabled devices, and the big data analytics as the new approaches in terms of taking the best out of digital health agenda. While this whole thing gets done, the most critical element in terms of creation of electronic health record is to ensure continuity of care across the health spectrum. And in totality, we end up supporting the universal health coverage. And this is what is the overall bigger goal, sir. So thanks a lot. I thought just I'll put this framework across to all the colleagues who are present here. There is so much to be done, but I feel that what is very critical when it comes to India's approach towards digital health is that we are in the right direction. When we came up with the National Digital Health Blueprint, and when we said that the citizen is going to be the owner, I still remember our colleagues from US asked me, they have a problem, the data is owned by the hospitals where the data is created. Herein we have empowered citizens because our focus has been always utilizing digital health as an agenda for being patient-centric and to ensure continuity of care across the health spectrum for the patient. I'll stop here, sir. If there are any other issues, I would like to intervene. Thank you very much.
Thank you, Mr. Agarwal. I think that has been a very informative and very lucid presentation. Thank you so much. In fact, I will request all the three panelists to kindly share their PowerPoint presentations. I think very informative presentations all that they have made. We have two or three, but I can group them into two. One is the National Digital Health Mission is a Government of India initiative. Now, but health being a state subject, how are the states involved in carrying this thing forward, the digital health part of it? And what sort of a facility they have to create at the state level to see that there is a seamless integration of what you are doing or what you are thinking in terms of covering the country and the state government's own vision. So that is one question, which I think I will address to you, Mr. Agarwal. The second question is the cost effectiveness of this whole thing. With how cost effective is digital health compared to the conventional health, especially in reaching the last mile, the rural areas, the remote areas, where there is hardly any internet, there is no broadband, there are no computers. So is it still cost effective to take it to the last mile? That is another thing that I think some of the members in the audience would like to know. But the first question is to you.
So, sir, let me respond to both the questions. I think,
okay, great. That's fantastic.
So, what is very critical for us to appreciate that health is a state subject. Whatever initiative, whatever framework we are building, these are all built in consonance and in collaboration with state. So even when the National Digital Health Blueprint was finalized, which talked about creation of National Digital Health Mission, it was primarily state level consultations which were done, their inputs were taken, and based on this framework is created. When we talk about interoperability, we need to understand and appreciate that a patient from Bihar may be visiting Delhi. From Delhi, he may even be going to Mumbai. So what is very critical for us is to create a framework where interoperability should not end at the state level. And that is where Government of India will basically support and collaborate with state to create this interoperability across the country. Second mechanism we have in terms of working, in terms of implementation approaches, that what we are requesting states is that under National Health Mission, all the states, based on the overall framework given or proposed by Government of India, they propose a lot of activities, be it implementation of e-hospital, be it launching and taking up of telemedicine application, be it even populating data in terms of COVID-19 portal, and then understanding what corrective action they have to take based on the dashboard available to them. So I think what is very critical is that we have involved them in day-to-day implementation. What we have discussed and highlighted to them also, that if you even take up an initiative at your level, and this is very critical to highlight here, that even if you take an initiative at your level, kindly take that initiative in consonance with the mission approach. Second is, you should always think that it is going to be expanded to the country. So you take an initiative, you launch a pilot, you make it successful, come back to us, and then we'll collaborate with all the state and make it a pan-India initiative. So that is one very interesting thing done. When I talked about telemedicine and 14 lakh plus telemedicine calls which have been done, they have primarily been done under a hub and spoke model by state doctors only. On the second issue, in terms of cost effectiveness, I think, sir, the question itself is the answer. Because anywhere, if I were to collect the data in paper and then transport paper, I won't even understand what is hitting me. I need to use technology. The moment there are more than 1, 2, 3 locations, technology as a tool is the only tool available to us to sort of consolidate everything together and make a meaningful intervention. If I were to manage COVID today as government of India or as state government, if I don't get the data of what is happening in Bidar and what is happening in, say, Almora, how will state government decide what interventions to take? So basically, whatever we are collecting on paper, we are actually utilizing technology as a tool, not to collect it multiple times, collect it once and make it available to everyone. So from a perspective of how digital health operates, I think it is cheaper than the normal paperwork movement, and it is more useful and more efficient. Second is, now the challenge is again in terms of the connectivity part. So what is very critical for us to think is that how do we create technologies which can actually work on low bandwidth? So to give you an example, one of the teleradiology application we had initially created, that application was working on national knowledge network connectivity, which was a lead line approach. Then we started working, we said we need to ensure that every PSC which has low bandwidth should be able to use teleradiology. And that is where we started working in terms of creating those applications where with low bandwidth also services can be provided. And telemedicine is a very critical example. Can I get the specialist service sitting somewhere in Himachal Pradesh or sitting somewhere in, let us say, in Chhattisgarh or Jharkhand, in a far off remote tribal belt, if I do not have telemedicine as an application? So we need to sort of come up with those applications which are user friendly, which are low bandwidth based, and which actually engages consumer. And we need to use technology as a tool, because that is probably the only most efficient way of managing health today.
Absolutely. Absolutely. I think basically whenever a new technology comes, this question always comes in, whether that is more cost effective or not. But ultimately it is proved, yes, it is cost effective. But that question I would like to pose it to Patty and Paul also, whether they have anything to say about the cost effectiveness of the technology. Paul, you have briefly mentioned about it, but if you can just in a minute.
Yes, of course. Thank you for your comments, Mr. Lavakarwal. Our focus initially, I'd mentioned about some of those elements, and what you mentioned is rather complementary. When it comes to cost effectiveness and digital health, and I'll emphasize the part that we work on, which is digital learning and large scale training to the last mile in multiple languages, in multiple topics. And it's the kind of effort that is needed, whether it's large scale rollout of COVID or any new program or introduction of new technology, whether it's vaccines or whether it is a new diagnostic or a last mile patient-centric product, is that we've seen, and there's a whole move away from this per diem and trainings and classroom-based, etc., because nor is it scalable, nor is it affordable. And ministries of health across the countries we are working in have realized there's a savings of almost 90% when they move towards digital learning. And beyond the cost, though, one, of course, aspect is the cost. The other elements, we can actually measure the learnings, we can measure the change, we can measure behavioral impact if the approach is designed well and is going to capture it as well, which needs to be done upfront in terms of how it is structured. So cost effective, absolutely yes, but also in terms of value for money and the ability to measure impact makes it even more powerful.
Thank you.
Thank you.
Patty, anything from your side?
Yeah, I would absolutely second Paul. I think the cost effectiveness is one of the selling points for deploying digital technology widely. It also allows for a scalability and a customization to different languages and different local settings. So any applications we can see in any country could be very easily translated or localized by just replacing, the interface or the pictograms or the actual language. So I think the cost effectiveness, value for money, and affordability for scaling things up as a global product to reach millions of customers is the main thing why we should all really invest in digital technology in healthcare.
Thank you. Thank you very much. I think that has been an excellent round of discussions we had on digital technology. Now, I would now pass on to Professor Justice Lokor, Madan Lokor, who is here watching the show, and then he has given the introductory remarks. Now I would request him to give the closing remarks before we wind up. Over to you, Justice Lokor.
Yeah, thank you, Mr. Prasad Rao. It's been a magnificent session, if I may say so, where there's been a lot of learning, a lot of experience sharing, a lot of knowledge that has been disseminated. But I would just like to mention 4, take-home points which I have picked up from today's webinar. Firstly, the awareness of public health issues and initiatives that are already existing is extremely important. I think that was emphasized by Paul, including the use of resources, mobile technology. I think that has been emphasized by everybody, all the panelists, and connectivity to the last mile. So in the use of resources, we also have local resources, things like ASHA workers, Anganwadi workers, self-help groups like you have in Nepal and other parts of India as well. The idea is to involve everybody, whether it is institutions or whether it is individuals. I think collectively the idea is to work together for improving public health. Number 2, early warning and prevention. I think this was also emphasized by Patty and also by Paul. Use of mobiles, mobile phones, as in Nepal, Nigeria, innovation through games, and thinking out of the box. I think that is also extremely important, so that you can reach out to people in different methods which are more user-friendly or more attractive to them. The use of drones, artificial intelligence, machine learning, I think remarkable suggestion, and it has been used effectively. Social media, this is something I think we need to look at it in greater depth. It has been used effectively, as Patty pointed out, when the swine flu hit the world in 2009. Number 3, training, which is very effective for empowerment and capacity building. But along with that, I think it is also important when we talk about empowerment, capacity building, and so on, we need to include infrastructure. It's not enough if we are in a position to share knowledge or learn if the infrastructure is not available. Finally, the digital health management mission, which was emphasized by Mr. Love Agarwal. There are a variety of applications, and I think this is probably something which has helped India to somehow or the other control or keep in check the COVID-19 pandemic. So far as vaccination is concerned, I think Mr. Agarwal has made it very clear that India is absolutely ready, thanks to the use of technology, really, to get ready for the future. And I liked his statement that India is driving the agenda on digital health. So I think once we look at digital health, in a global perspective, India's contribution to it, I'm sure we can bring about the change that all of us are looking for. So thank you very much to all the panelists and to everybody for this wonderful experience. Thank you.
Okay, thank you very much, Justice Lokor. Now to Dr. Rajani Wadhwa to give a vote of thanks to all the panelists and the viewers.
On behalf of Plan India team, I would like to extend my heartiest thanks to everyone who's been a part of this webinar today. Thank you, Justice Lokur, for your presence and paraphrasing the discussions. It's always an enlightening experience interacting with you. Mr. JVR Prasad Rao, you are an exemplary person and we have a lot to learn from you. Thank you for moderating the sessions today and always supporting and guiding us. I wholeheartedly thank the panelists, Professor Paul, Professor Patty, Mr. Love Agarwal, for your presence today, despite the busy schedules, and sharing your experiences and some great work with us. Congratulations to the organizing committee for putting this all together. Last but not the least, I thank all the participants for their presence today and their questions that made the discussions engaging. Please keep an eye out for our next webinar in a couple of months. I hope you will find them useful. Thank you again, everyone, and have a good evening.
Thank you.
Thank you.
Thank you.
Thank you all.
Thank you.
Thank you.
Thank you.